Moscow. This is the second time that I'm here. I was here 3 years ago, and I'm very pleased to come back here. It's a beautiful city and a great festival. And after a pretty hard morning, I was asked to talk about pancreatic cyst. I did a similar lecture 3 years ago about pancreatic cyst. Today I will talk about mostly of intraductal papillary mucinous neoplasms, and this lecture is totally different from the first lecture, although we don't know much in these 3 years, but still I arranged a different topic. So we'll start in general. We have the histologic classification. We have the serous cystadenoma, which mostly we have the serous cystadenoma, and we have the solid pseudopapillary tumors. And on the mucinous pancreatic cyst, we have the mucinous cystadenoma mostly, and we have the intraductal papillary mucinous tumors, which I will talk about it today. What about the prevalence of cysts in our population? When I'm sitting in the clinic nowadays, many more patients come concerned about the pancreas and pancreatic cyst, and this is because we are doing a lot of imaging studies nowadays. It depends on which imaging we are looking for. If we are looking about CTs, we will find about 2% of pancreatic cyst in the population. If we are looking about MRI, we'll find about maybe 20% of pancreatic cyst in the pancreas. And if we are looking about MRCPs, we can find even 45% of pancreatic cyst that we will find incidentally. It's also very important on what kind of population are we looking for. If we are looking about young patients, they will have a low prevalence. If we are looking at older patients, 50 and more, you may find 40–50% of patients with pancreatic cyst. So it's going to be a huge problem in the present and in the future, maybe more. Let's start from the beginning. The first time that the IPMN was described was in 1982. A doctor saw that pancreatic adenocarcinoma with dilated main pancreatic duct. He saw a mucus secretion in the pancreatic duct and a patulous ampullary orifice which was different from the other adenocarcinomas that we knew before. If we're going to speak about the prevalence of IPMN, I can't answer this question because it's difficult to say from all the cysts how many IPMNs there are, because most of the patients come from surgical departments like here, from high center volumes, and the incidence and the prevalence of IPMN is still not really known. We can know that from all the pancreatic cysts that we have in the population, the most prevalent one is the IPMN. We have about 12% of mucinous cystadenoma. We have maybe 20% of serous cystadenoma, and more than 50% of the pancreatic cyst will be IPMNs and others. What about epidemiology? What we know about IPMNs? The typical age of presentation, it's about the 5th to 7th decade. The male to female ratio is about the same, although it will be a little bit higher in men. Most of the IPMNs are in the head and the uncinate process, and we know about risk factors. We know about smoking, diabetes mellitus, FAP, Pauch-Jaeger syndrome, and familial pancreatic carcinoma is also a risk factor for IPMN. Classification, very important. We have first the main duct type IPMN. It involves the main pancreatic duct. It could be diffusely dilated or segmental dilation of more than 5 millimeters. It most arise at the head and the uncinate process, but can involve the distal part as the tail afterwards. We know that the main duct is more aggressive and more likely harbor a malignancy. The second type is the branch duct IPMN. It's in younger patients. It also arises mostly in the head and the Mucinous process, but may involve the body and the tail. We have a low risk of malignant transformation. And the third classification is the mixed type that I will talk about later on. What about histologic subtypes? You are surgeons. After resecting these patients, you can say that there are 4 subtypes of histological classifications. The first and most common histologic type is the intestinal type. It occurs in the pancreatic head. There is a villous growth pattern in the biopsies. It may involve the entire duct, and when invasive, it can produce mucinous carcinoma with stromal pools of extraluminal mucin. The second subtype is pancreatico-biliary. It typically involves the main duct of the pancreatic head as well. It composes a papillary arborization, and it could be invasive with ductal adenocarcinoma at the end. The third subtype of IPMN is the oncocystic type. It is rare. It also involves the main pancreatic duct and may produce little mucin. It's composed of complex papillary like pancreatico-biliary, IPMNs, and maybe eosinophilic ahead. The fourth type is the gastric type. It's mostly on the branch duct IPMN. It's the most common subtype overall from all the subtypes. It's typically in the peripheral of the pancreatic parenchyma, but as we said, for branch duct IPMN, it's mostly at the head and the Mucinous process, and it resembles the gastric foveolar cells with pyloric gland-like structures at the base of the papilla. What is the clinical presentation of most of the patients with IPMN? Most of them are asymptomatic. We are finding these IPMNs, these pancreatic cysts, incidentally by imaging studies for unrelated indications. Other non-specific symptoms could be nausea, vomiting, abdominal or back pain, weight loss, or anorexia. In main duct IPMN, there could be obstruction with pancreatitis-like symptoms with the development of exocrine and endocrine insufficiency. In some of the patients, we can see on the lab examination an elevated amylase and lipase levels, and as I will talk about it later, we may see a CA 90.9 and CEA levels elevated in the serum bloodstream. Diagnostic imaging of IPMNs. We can start, as we saw today, ERCPs. Typical findings in the ERCP is a diffuse or segmental dilation of the pancreatic duct without strictures, as we can see in chronic pancreatitis. There could be dilation also of the branch duct of the pancreas. There could be a filling defect on the main pancreatic duct. It could be a mucinous or mural nodules, of course. And we can see a papilla and patulous papilla, which is a fish mouth appearance that is very significant for IPMN. The advantages of doing an ERCP is the ability to take cytology by aspiration of the mucin or doing brushing to see the pathology. We can also take molecular markers such as KRAS, GNAS, or other telomerase and study if we can say something about these molecular markers. EUS. The typical findings that we can see in EUS is a segmental or diffuse dilation of the main pancreatic duct. We can see mural nodules in the duct. In branch duct IPMN, we see the multiple small cysts from 5 to more millimeters. We can do an FNA and send the cystic fluid for analysis. We can see the mural nodules, and we can bite by FNA and take pathology. The advantages, it may distinguish between branch duct IPMN and other cysts. We can use contrast-enhanced EUS to see if there is enhancement of the nodules and to distinguish between nodules and mucin. And we can do a distinction between IPMN and chronic pancreatitis with classifications and other signs of chronic pancreatitis. We are doing in US and we are doing FNA and we are sending the fluid for analysis. We can send to CEA. The CEA is good to distinguish between mucinous and non-mucinous neoplasms, but it's not good to distinguish between benign and malignant cyst. The level of CEA above 192 to 200 is 80% accurate for the diagnosis of a mucinous cyst. It could be mucinous cystadenoma or IPMN. We can send the fluid for amylase levels, and if it is elevated, it's more pronounced for IPMN or pseudocyst maybe. We can send the fluid for cytology, although the sensitivity is limited because the paucicellularity of our fluids in cytology. We can also send the fluids for molecular markers and analyze KRAS and GNAS maybe in the future. But in 50 to 60% of fluid samples, the FNA is not diagnostic. As we can see in our daily, everyday practice, there is a few cytology that can help us by doing FNA. And if we have a simple cyst without worrisome features, I do not recommend to do an FNA because it won't help us to distinguish between the cyst. As we have done here, spyglass system for the CBD, we can use spyglass for the pancreas. We have a dilated main pancreatic duct. We can go inside with a spyglass system, and we can see the main pancreatic duct from inside. It helps to see the involvement of the cyst all the way to the main pancreatic duct. We can see if there is skip lesions, there is papillary lesion at the head, neck, or elsewhere. There are suggesting malignancy features that we can see, fish egg-like lesions, villus proliferation, but in the literature there is only about 400 patients that did pancreascopy on main pancreatic duct, so it's hard to say if it is really helpful or we are risking our patients with pancreatitis. Another gadget that we can use is intraductal ultrasound. We can insert the probe inside the main pancreatic duct. It helps also to determine the tumor extent inside the main duct. There are limitations because of the high frequency waves that we see only the few millimeters around the main duct, and we don't see what is far away from the probe, so it won't really help us. What about CTs and MRIs? They are good to assess the tumor, the relationship to other structures, if there is a lymph node involvement, a vascular involvement, or if there is a metastatic disease far away. They are good also, the CT and the MRI, to detect mural nodules. We can inject contrast and to see if there is an enhancement in the nodules. And MRCP is very good at determining if there is a communication between the side branch and the MPD, and to distinguish between bile duct, IPMN, and mucinous cyst adenoma. Let's talk about the natural history of IPMN. There is a progression, like in polyps, from benign to true malignancy at the adenoma, carcinoma, invasive carcinoma pathway. The time of the degeneration of this pathway and the molecular pathway involved in this natural history, we don't know, we are still looking for. Now let's talk about the natural history of IPMN when we are subdividing the profile risk of BD IPMN and main pancreatic IPMN. We see that if we are surveying the people with IPMN, there is a big difference between branch duct IPMN and main duct IPMN and mixed duct IPMN. In following these patients for months, there is a 15% of these patients to develop carcinoma in the branch duct IPMN, and in the main duct IPMN and mixed duct, there could be a 63% of involvement of carcinoma later on. So these are two different diseases, as we can see by these graphs. This is also a very, very busy picture of the natural history of IPMN from the revised secondary criteria. Also, we can see here that in main pancreatic duct, we have about 43% of involvement of carcinoma later on. In mixed type, also more than 40%. And in branch duct, IPMN, about 15 to 16%. So these are different diseases, and we need to treat it differently. Let's talk about management of IPMN. We are doctors, all of us, and we are using the evidence-based medicine level to suggest what we are doing with our problems. When you're looking about the history of IPMN, it was first described, as I said, in 1982. And later on, there is three kinds of classification of the Hugh system. And afterwards, there is three guidelines, the Sendai consensus in 2006, the revised Sendai in 2012, the European Consensus Expert at 2013, and the American Gastroenterology Association at 2015. So if we have too many guidelines, it says that we don't know much about the disease, and it's hard to make a decision about the management of these people. Why this is hard? Because we have many complexities. We maybe have two different diseases. We don't have much alternatives unless going to follow-up or surgery. There is a high risk in every one of our decisions, and we need to think about life expectancy of these patients, the surgical risk, the cost of the surveillance of these patients, and the most important thing is to individualize the patient according to the risk and benefit profile of our decision. What do we know? If we are taking the patients that underwent resection for main pancreatic duct, we see that in our pathology, most of the patients have or high-grade dysplasia in 72% of the patients, and invasive carcinoma in almost 40%. So we know that main duct IPMN have a high malignancy rate, and if we are going to resection, it has a favorable prognosis for the patients. So they can say that if we have a patient with a main duct IPMN and it's surgically fit patient, we can take this patient for resection. The big problem is with branch duct IPMN. What to do? Observe these patients, resect these patients, how we would decide what to do with these patients. As I said, do not worry because we have guidelines. We talked about the Sendai in 2006. Sendai in 2006 consensus guidelines says that if you have an MD IPMN of more than 10 millimeters, if you have a BD IPMN, branch duct IPMN of more than 3 centimeters, or a cyst with symptoms, or a cyst with mural nodules, or a dilation or positive histology in this cyst, you should take these patients to surgery. Afterwards, we have the revised Sendai in 2012. The revised Sendai tried to predict malignancy by dividing these patients and the criteria to high-risk stigmata and worrisome features. In high-risk stigmata, the prevalence of malignancy is 50 to 70%. These patients may present with obstructive jaundice. They have enhanced solid component in the bile duct, and the main duct is 10 and more than 10 millimeters in size. These patients have high-risk stigmata, a high prevalence of cancer, we can take these patients for surgical resection if they are fit. The second part of the revised Sendai consensus is the worrisome features. If the patient is clinically suffering from pancreatitis, if on imaging we have a cyst that is above 3 centimeters, if the cyst has thickened or enhanced wall, if there is a non-enhancing mural nodule, or the main duct is 5 to 9 millimeters, or there is an abrupt change in the pancreatic duct by imaging, we should take these patients to EUS and try to do an FNA for this cyst and analyze this cyst by what we are seeing and what we are dealing with in the fluid, and then decide if these patients will go to observation or resection. If we are not sure, although we have the Sendai or revised Sendai, we have other guidelines. The European Consensus Guidelines in 2013, they have risk factors for IPMN with the potential for malignancy. If the patient is symptomatic, if the size is not 3, but 4 centimeter big, if we have mural nodule or dilation of the MPD, or elevated CA 90.9 at the serum blood, this patient have risk factor and we should think about surgery. In 2015, the American also want to write something about the consensus, and they also have their own guidelines. A few words about CA 9.9. If we measure preoperatively these patients in the serum blood, in 142 patients after went to surgery, in invasive IPMN, we have CA 19.9 level of more than in 74 patients elevated. In the patients with non-invasive IPMN, the CA 19.9 will be only 14 percent. The cutoff of this tumor marker is only 37 units per ml. So if we have a patient with an elevated serum CA 19.9 in the serum blood, this patient may have a significant risk for malignancy. As in the European consensus, they wrote that this is a risk factor and we should think about surgery. I'm not fond of statistics and I'm not good at it, but there are also literature about nomograms. We can take a few parameters of the patient, like age, the diameter of the main pancreatic duct, the cyst size, if he has mural nodule, and put all these factors in a calculator and try to find the risk for invasiveness in this patient. It may help, still not on the everyday practice. What about molecular profile? Does it help us to manage these patients? The most molecular profile signs and markers that we know in the literature is the GNAS and the KRAS. They have a high level in patients with IPMN, and in some studies they have shown that high levels of these two molecular markers, there is also a correlation for dysplasia. So we don't know yet, but maybe it will help us in the future. What about radiology? How can they help us to manage these patients? When we are going through the literature, we see that in imaging studies, the most suspicious thing for malignancy in branch duct IPMN is mural nodules. It's not the cystic size, it's not the dilation of the MPD. If the patient has a mural nodule inside the cyst, this patient should consider for resection. So we can do a checklist, like the European consensus wrote. If the patient is symptomatic, if he has mural nodule as we saw on imaging, if he has a dilation of MPD of more than 5 and less than 9 millimeters, if he has an elevated serum CA 19.9 levels, or if he has a growth rate of the cyst of more than 2 millimeters per year, if one of these risk factors is present in our patient, we should consider a resection and not observation. I will say a few words about mixed type IPMN. In most of my talk, I mentioned mixed type as a main pancreatic IPMN. But when we are looking at resected patients that had mixed type IPMN, we have two different diseases. We have patients with minimal involvement of the MPD, and we have patients that have extensive involvement of the MPD. So not all the mixed type IPMN are the same. There is minimal with more gastric type epithelia in their pathology, and there is a mixed type with extensive involvement with intestinal type epithelium, and these diseases are different. In the mini type involvement, they are better disease-free survival, and in the extensive, they have a worse disease-free survival. So these patients are different. I can't say how we can differentiate these patients before we go to surgery, but we should know that also in the mixed type IPMN, we are not talking about the same patients, and there are subtypes. So, the role of surgery in IPMN. We decided that this patient may go to surgery. Which kind of surgery we want? We want a complete resection of the high grade and the malignancy lesion with minimal probability of recurrence of this malignancy. We want to preserve the pancreatic function as much as we can. We want surgery with low morbidity and mortality, and we want a standard pancreatic resection. We don't want to improvise anything we don't know. So we can choose the segmental resection in the majority of patients. When we are doing the segmental resection, we are checking the margin of the resection with frozen biopsies and extend the resection up to total pancreatectomy if we need, with the frozen biopsies in the surgery. So we resect the patient, the pancreatic, and we are sending for frozen section. If it's normal, we can stop. If on the margin we have dysplasia or carcinoma, we're continuing the resection and sending also a frozen section. Again, if it's normal, we can stop. If we have still dysplasia or carcinoma in the margins, we need to continue until we have a good margins with normal parenchyma. What about the follow-up of these surgical resected IPMNs? There may be a residual IPMN in the pancreas. There may be cysts that we didn't resect. There could be a residual IPMN in the margins with no dysplasia that we didn't resect, or they will develop new lesions in the future. What we are doing in our clinic, we are yearly follow up these patients for radiation imaging. We are doing an MRI or EUS with non-radiating imaging, with MRI or EUS. And if we have another suspicious lesion and this patient is surgically fit, we will have to send him back to the surgeons. If on imaging we are free from disease, we can follow him year after year. So, what will we do with all the information we talked about? I'm using preferably the Sendai revised in 2012. I'm using the high-risk stigmata for the patients that I send to surgery. I use the worrisome features and do an EUS and then decide if these patients will be better with surgery or follow-up. And if follow-up, it depends on the size of the cyst. If the cyst is small, we can continue with CT MRI every 2 to 3 years if it is less than 1 centimeter. If the cyst is about 1 to 2 centimeters, we can do CT MRI or maybe EUS yearly for the first 2 years, and then with higher interval until the end of these patients, until he's surgically fit. If the cyst is bigger than 2 centimeters but less than 3 centimeters, we can do EUS every 3 months and then later on every year and see if we have worrisome features, and afterwards to decide if observe or resect. If the cyst is more than 3 centimeters, we have close surveillance with EUS or MRI every 6 months, and then observe the patient and decide if the future is okay or we need to send him to surgery. For summary, IPMN is a precancerous lesion. The diagnosis usually requires the combination of endoscopic ultrasound and radiographic methods. The CT and MRI are perfect. The resection is still recommended in surgical fit patients for main proteatic IPMN and mucinous cyst neoplasms. If we have a branch duct IPMN with high stigmata and worrisome features, we need to stratify these patients for malignancy and send him also to resection. And the most important thing is a personalized medicine. We need to think about the patient, what about the malignancy progression, the operative risk, and try to do the best for the patients. Thank you very much.
Спасибо большое, доктор Phillips. Очень интересная, подробная лекция. Пожалуйста, вопросы кому угодно задать. Коллеги в зале. Марина Валерьевна, пожалуйста.
Да, у меня, если можно, есть вопрос. Большое спасибо, профессор Phillips. Вы рассказали о большом числе диагностических методов, которые могут быть использованы для постановки диагноза IPMN. Мне бы хотелось попросить вас назвать основные ключевые методы, на основании которых мы можем ставить диагноз и определять дальнейшую тактику лечения, потому что, к сожалению, в России мы не всегда можем использовать весь полный спектр названных тестов.
Okay, a very good question. As I spoke about, we have the CT and we have the MRCP and the EUS. When we are talking about worrisome features, the CT and MRI are perfectly good. The MRCP is more accurate at imaging the connection between the cyst and the pancreatic duct, and to classify the cyst as branch duct IPMN. So I would prefer MRI, MRCP on CT of diagnosis the patients and of following these patients. If the patients have worrisome features, as I spoke about by the revised SENDI, I preferably follow up them with EUS, because on EUS, we can see clearly the communication. We can see if there is a change in the diameter of the MPD. We can see mural nodules. We can use the enhanced contrast to see if we have enhancement of these mural nodules and to distinguish between mucin and nodules. So MRI, MRCP, and EUS are preferred, and the follow-up it depends on the patient. If he has a big cyst and with worrisome features and is not on the way to resection, I would follow him up every 3 to 6 months to see that there is no involvement of this cyst.
Спасибо большое за подробный и полный ответ.
Спасибо. Пожалуйста, вопросы, есть ли у вас? Я смотрю, что в президиуме пока вопросов нет, а в зале? Алексей Степанович, пожалуйста.
Я вас тоже благодарю. Скажите, пожалуйста, что вы понимаете под резекцией протоков, как переводит нам переводчик? Резекция протоков как метод лечения. Это эндоскопия, резекция панкреас или что-то другое? И существуют ли методы лечения, когда маленькие опухоли, и можно какими-то методами ее ликвидировать, уничтожить?
No, I'm not talking about. I'm not talking about duct resection. I'm talking about segmental pancreatectomy. You need to resect all the pancreas in the involved area. If this is for the main pancreatic or a branch duct IPMN that it has high-risk stigmata or worrisome fixtures, you need to resect the whole pancreas and not the duct alone. While resecting the pancreas, you are checking the margins of the pancreatectomy, and if you have a high-grade dysplasia or carcinoma, we are continuing with pancreatectomy. If you have a free margins with normal parenchyma or maybe low-grade dysplasia, you can finish the resection. But you need to do pancreatectomy and not only enucleation of the cyst or resection of the duct alone. It's pancreatectomy.
Спасибо, сударыня, и вам спасибо.
Есть еще у нас вопрос, Андрей Михайлович, да?
Может быть, комментарий небольшой. Для того, чтобы не было разночтения терминологического, поскольку главный панкреатический проток, поражение главного панкреатического протока требует удаления, выполнения панкреатодуоденальной резекции, то в зависимости от локализации в главном панкреатическом протоке, если это головка поджелудочной железы, речь идет о панкреатодуоденальной резекции. Если это дистальные отделы главного панкреатического протока, с целью сохранения части органа выполняют дистальную резекцию поджелудочной железы. Поскольку считается, что поражение боковых браншей является лишь предтечей и начальным этапом распространения в сторону главного панкреатического протока, и рано или поздно происходит централизация, то есть то, что вначале было поражением боковых протоков, становится смешанной формой, то, как показывает практика и большинство мнений, при наличии отягчающих факторов выполняется тоже панкреатодуоденальная резекция. Вот, собственно говоря, то, что я хотел в дополнение к сказанному дополнить. Спасибо большое.
Спасибо. Пожалуйста, уважаемые коллеги, еще есть вопросы. Елена Алексеевна, пожалуйста.
I totally agree with you with the distal pancreatectomy and the Whipple procedures from the head and the distal part of the pancreas. We're thinking the same.
Глубоко уважаемый профессор Phillips, скажите, пожалуйста, каковы четкие показания для выполнения тонкоигольной пункции? В каких случаях она строго необходима? Если она выполняется, какое количество секрета необходимо забрать из кистозного образования, полностью опорожнить все, что доступно? И необходимо ли в этой ситуации проводить антибиотикотерапию?
Thank you for the question. I'm doing FNA in the patients that have the worrisome features. If the patient has more than 3 centimeters size of the cyst, if he has a main pancreatic duct, a mixed type of 5 to 9 millimeters, if there is a mural nodule, or if there is a thickness of the wall of the cyst. These patients that the CT and MRI was done and we still have some features, I puncture the cyst and send them to cytology and to CEA levels and to amylase levels. I'm trying to get as much fluid as I can, because if we want to reduce the risk of infection after puncturing the cyst while leaving the less fluid inside the cyst, we have the less risk of infection in these patients. So I'm trying to aspirate as much as I can. I'm giving antibiotics to all the patients while doing the FNA and also 3 days afterwards because of the risk of infection. And there was another thing that you asked. You're welcome. And also in surgical fit patients. We are not doing it in Israel, and we are not, I don't know if we're doing it elsewhere. In my clinic, I also follow patients that are 75, 80 years old patients with comorbidities, and they are very anxious about their pancreatic cyst. And these patients are not surgical fit for resection, and these patients would not need a follow-up for that cyst because I won't decide to send this patient to surgery, but because they do know that they have problem with the pancreas and they are very scared about it, I keep following them. And in these patients also, I wouldn't do an FNA because it wouldn't change the mind if I will resect them or observe them.
Я хочу обсудить буквально в нескольких словах вопрос о том, вообще показано ли, есть ли необходимость антибиотика превенции каких-либо осложнений при выполнении тонкой игольной пункции аспирационной. Ведь выполняя ретроградное вмешательство, ту же самую панкреатикоскопию, панкреатикографию, мы ведь не назначаем пациентам антибиотики, несмотря на то, что прямое проникновение эндоскопическим инструментом в протоки. Нет в этом необходимости. Другое дело, какова должна быть диагностическая тактика, поскольку эффективность тонкоигольной пункции, она недостаточно высока. 40-45%, как правильно вот указал наш уважаемый гость, профессор, этого ниже 50-50, 45%. Поэтому в тех учреждениях, где есть возможность применения спайглаз с каналом, выполнения, поскольку, собственно говоря, название этого патологического состояния киста достаточно условное, это расширение протоков, связанное с нарушением оттока муцинозного содержимого. Поэтому вы получите муцинозное содержимое. Понятно, что это муцин-продуцирующая опухоль, а раз это так, то, скорее всего, это не МСН, а IPMN. Вот выполнение щипцовой биопсии через спайглаз, да, это достаточно такой эффективный способ верификации диагноза, а тогда уже в зависимости от наличия или отсутствия отягчающих факторов, это размеры, это клиническая симптоматика, манифестирует клиника или нет, вот тогда принимается решение о том, как быть. Либо динамическое наблюдение, либо операция в том или ином объеме. Спасибо.
Извините, Андрей Михайлович,
Пожалуйста, Марина Валерьевна.
У меня есть некоторые комментарии к вашему дополнению. Поскольку у нас здесь и обучение происходит, в том числе, я, к сожалению, не могу с вами согласиться в вопросе антибиотикотерапии. И на самом деле в зарубежных гайдлайнах абсолютно четко предписывается в обязательном порядке использовать введение антибиотиков за сутки, в день процедуры и на следующий день после при выполнении любых интервенционных вмешательств на билиарном тракте, в том числе и при обычной диагностической РПХГ. Доказано, что бактериемия происходит в течение 3 суток. после процедуры. И даже когда мы прекрасно и адекватно восстанавливаем отток желчи, удаляя камни или устанавливая стенд, в обязательном порядке необходимо назначение антибиотиков, поскольку в противном случае холангит в том или ином варианте у пациентов развивается.
I agree with both of you. It's politically correct. For FNA and EOS, by literature, we need to give antibiotics and to reduce the risk of infection. So we don't have much to say about this. About ERCP as well, so there is indications to give prophylactic antibiotics in transplant liver patients, in patients with primary sclerosing cholangitis, patients that there is incomplete drainage after doing an ERCP because of a tumor or stones. So the decision to give antibiotics, it doesn't mean it need to be very high, because if we are afraid that these patients will complicate with infection, we should give them antibiotics. For the suggestion of pancreatoscopy in IPMN, as I said, there is only 400 patients in the literature that have done this procedure. The main indication is a patient with a main pancreatic IPMN. They need to have a large diameter of the MPD to go with the spyglass system. And these patients, I have to say, they have indications for surgery before the pancreatoscopy. It can help us in academic things to take molecular and biological markers. It could help us to extend the disease if the disease is in the head or the neck or the body. But I truly believe that these patients have the indication for surgery before the pancreatoscopy. It's nice pictures and it's very delightful to do this, but I don't really know how much it will help the patient or the surgeon.
Спасибо большое. Ну что же, уважаемые коллеги, Андрей Евгеньевич, пожалуйста, микрофон у вас.
Я должен сказать, что сама по себе панкреатикоскопия – это совсем непростая процедура. Я знаю это не понаслышке, а потому что первую панкреатикоскопию я сделал в 1985 году, используя ультратонкие аппараты фирмы «Олимпус». И должен сказать, что я согласен, солидарен с Мариной Валерьевной о том, что здесь после этой процедуры и во время этой процедуры, не говоря о том, что чрезвычайно сложно получить изображение, потому что невозможно ввести достаточный объем прозрачной жидкости, это все должно быть контролируемо, все это травматично. В обязательном порядке больные должны были быть подготовлены желательно до и после вмешательства. Ну, так не всегда получалось, но после в обязательном порядке, потому что сама она по себе, панкреатикоскопия, это достаточно непростая, как я сказал, процедура и травматичная. Поэтому неважно, что сделали сейчас, спайглазом, не спайглазом, сама по себе визуализировать панкреатический проток и интерпретировать состояние слизистой панкреатического протока – это не такая простая процедура, поверьте мне. А уж предотвратить последующий острый панкреатит, который может развиться, он развивался, Это тоже основная задача. Поэтому, с одной стороны, это диагностика, а с другой стороны, нет ли связи ради диагностики получить серьезное осложнение. Вот это те весы, на которые нужно положить эту технологию. Вот что я хотел сказать.
Спасибо, Андрей Евгеньевич.
Можно еще тогда?
Алексей Иванович, вам можно?
Если есть время.
Да, есть немного времени.
Мы более широко в этой аудитории, в аудитории практических врачей, затронули эту тему. Применение антибиотиков. Кто-то на собственном опыте, кто-то на опыте своих пациентов имел осложнение от применения антибиотиков собственно. Второе – это все-таки материальные затраты. Для того, чтобы решить вопрос, на мой взгляд, надо применять антибиотики или нет, надо определиться с состоянием больных, имеется ли у него осложнение или нет. По моему опыту, вмешательство у больных с неосложненных, без желтухи, без холангита, у них частота осложнений после вмешательств всегда больше. Как только мы начали ретроградные и в 90-е годы лапароскопические операции, лично я, если я решал вопрос, антибиотики не назначал. Никакая лапароскопическая хирургия не требует применения антибиотиков, на мой взгляд. Антибиотики надо применять, и они абсолютно обоснованы, если имеются показания. То есть у больного, собственно, профессор говорил о риске. Вот риски, которые вообще имеются в хирургии, применительно к эндоскопической хирургии, они имеют место. Это состояние больного, общее, локально наличие или отсутствие осложнений, и самое главное, дренаж, имеется ли дренаж панкреатических или панкреатического содержимого или желчи. Если дренажа нет, антибиотики возможны. Я всегда задаю себе вопрос, а сколько же концентрация какая там где-то антибиотика возникает, чтобы она смогла уничтожить инфекцию? Локальные антибиотики, если есть дренаж, стент и так далее, то, наверное, местное применение эффективно. Общее же, на мой взгляд, сомнительно. Поэтому назначать антибиотики нужно строго по показаниям, а не каждому больному после вмешательства. Спасибо.
Спасибо большое, Алексей Степанович. Но это уже такой, мы широко немножко пошли относительно антибиотикопрофилактики, антибиотикотерапии. Давайте мы, наверное, в эту сторону не будем сейчас делать уклоны и разбирать такие более широкие вопросы. Я предлагаю от души поблагодарить нашего гостя, нашего доктора Phillips'а, за прекрасное выступление в операционной, за прекрасную лекцию, поблагодарить его, вручить ему замечательную книгу о Москве по традиции, да, в качестве сувенира о нашем замечательном, красивом, прекрасном городе. Пригласим его еще раз к нам в Москву и пожелать ему всего самого наилучшего. Thank you very much.
I will be happy. Thank you very much.
Уважаемые коллеги, мы включаемся в операционную